Somewhere in your home right now, there is probably a small piece of paper with a number on it. It came from your last blood test. It's labeled fasting glucose. And the number next to it was probably somewhere in the high 90s or low hundreds. And if your doctor glanced at it and said nothing, no concern, no comment, maybe just, that's fine, there is something about that number I want you to understand today. Because fine and normal are not the same thing as doing nothing to your nerves. A number that sits just under the line your doctor draws for diabetes can still be quietly affecting the peripheral nerves in your legs. The same nerves we have spent this entire series discussing. Not eventually. Now. Slowly, continuously, beneath the threshold of any diagnosis. Today, I am going to show you the mechanism behind that. What your fasting glucose number actually means for your leg nerves, even at levels your doctor calls normal. And 3 specific evidence-based habits that the research shows can directly protect your peripheral nerves from this kind of damage, starting with your very next meal. I want to tell you about a patient I'll call Harold. He was 70 years old. He had been experiencing the tingling and occasional numbness in his feet that we've discussed throughout this series. Mild, intermittent, easy to dismiss. His fasting glucose had been tested every year for the past 5 years. Every result came back between 98 and 106. Every single year he was told it was borderline, or fine, or keep an eye on it. He was never told he had diabetes. For real, he was also never told he had prediabetes. Because in some years his number landed just under that line, and in other years, just over it. And nobody connected the pattern across the 5 years. What Harold had, without ever being told what infertil, was 5 years of a nervous system operating in an environment that the research now associates with measurable nerve damage, not despite his normal results within them. Stay with me, because the number on Harold's lab report and the number on yours may be telling a story that nobody has read to you yet. Here is the research I wish every conversation about a borderline blood sugar result included, and almost never does. A prospective Canadian study called the PROMISE trial followed people around 50 years old who had risk factors for type 2 diabetes, but did not yet have it, over a 3-year period. At the end of those 3 years, the results were striking. Of the participants who developed prediabetes, meaning their fasting glucose or glucose tolerance had crept into the elevated but not diabetic range, 49% had peripheral neuropathy. Of the participants whose blood glucose stayed in the healthy range throughout the study, 29% had peripheral neuropathy. Read those 2 numbers again. 49% versus 29%. Prediabetes, a category that by definition is not diabetes, and that many doctors describe to patients as nothing to worry about yet, was associated with peripheral neuropathy in essentially half of the people who had it. Harold's 5 years of readings in 98, 102, 99, 106, 101 sit almost exactly inside the range this study is describing. Not diabetes by any single test, but year after year, inside the gradient where this research found neuropathy in roughly half the people living there. A 2025 systematic review and meta-analysis published in the European Journal of Neurology confirmed this pattern across the wider research literature. Prediabetes is consistently associated with a high prevalence of polyneuropathy with small nerve fibers, the fine sensory nerves in your feet and lower legs, affected first and most consistently. Now I want to show you exactly why this happens at the cellular level, because the mechanism is not abstract. It is something happening in the nerves of your legs through a chemical process with a name that sounds almost domestic. It is the same reaction that browns a steak in a hot pan, and it is happening, slowly, inside you. When glucose levels in your blood run consistently higher than your body is designed for, even moderately higher, even within a range labeled normal, glucose molecules begin attaching themselves to proteins throughout your body in a process called glycation. This is the same basic chemical reaction known as the Maillard reaction, the one responsible for the browning of bread crust, the sear on a steak, the color of coffee. It happens when sugars and proteins are exposed to each other, and over time, it changes the structure of whatever protein it happens to. When this happens slowly over months and years inside your body, the altered proteins are called advanced glycation end products, AGEs for short. AGEs accumulate in tissues throughout the body, and peripheral nerves are particularly vulnerable for two reasons. First, AGEs generate reactive oxygen species, unstable molecules that cause direct oxidative damage to nerve cells. Second, AGEs accumulate in the mitochondria, the energy-producing structures inside every nerve cell, straining the cell's ability to produce the energy it needs to maintain itself and conduct signals properly. A 2024 study published in a peer-reviewed journal described the result plainly. AGEs contribute to nerve damage through oxidative stress, chronic inflammation, and impaired cellular repair processes, all compounding each other over time. Here is the part that connects directly to everything else in this series. Age accumulation amplifies the inflammaging process we discussed in the gut video. It worsens the myelin vulnerability we discussed in the gut video and the overnight drainage video. It adds to the burden on a peripheral nervous system that may already be dealing with medication effects, lymphatic decline, and reduced overnight repair. Blood sugar is not a separate topic from everything we've covered. It is one of the inputs that determines how much repair capacity your nerves have left for everything else. And the critical point, the one that should change how you think about that number on your lab report, is this. The research describing this age-driven damage does not start at the diabetes threshold. The damage process is dose-dependent. It begins wherever glucose levels begin running higher than optimal, and it accumulates continuously from that point. Your lab report draws a line and calls one side normal and the other side diabetes. Your nerves do not see that line. They experience a gradient. Harold's nerves had been living somewhere on that gradient for 5 years. Nobody had ever described it to him that way. Now, here is what I most want you to take from this video. Because everything I have just told you might sound like the beginning of bad news. It is not. It is the opposite. Because unlike many of the mechanisms in this series, this one responds to changes you can make within days, not months. And the first one is something you could do after your very next meal. The first strategy, a short walk after meals, particularly after dinner. A study led by Dr. Loretta DiPietro at George Washington University took adults with an average age of about 60 and elevated but not diabetic blood sugar, and tested 3 approaches to exercise. 1 45-minute walk in the morning, 1 45-minute walk in the afternoon, or 3 15-minute walks, each beginning about 30 minutes after a meal. The 3 short post-meal walks controlled blood sugar as well as the single 45-minute session. And the walk after dinner was significantly more effective than either of the longer sessions at controlling blood sugar overnight and into the next morning. Dr. DiPietro explained why this matters specifically for people in this age group. As you age, your insulin response, the system that clears glucose from your blood after eating, becomes less efficient, particularly later in the day. Dinner tends to be the largest meal, producing the largest glucose rise at exactly the time of day when your body's natural ability to manage it is weakest. Going to bed after a large meal with elevated blood sugar is, in her words, one of the worst things for this pattern. The mechanism is direct. When your muscles contract during walking, they pull glucose out of your bloodstream and into the muscle tissue for storage, independent of insulin. A 2022 meta-analysis of 7 trials found that walking for just 10 to 15 minutes after a meal reduced the 1-hour glucose peak by an average of 17 to 24% compared with remaining seated. The practical version, a 10 to 15-minute walk, even a gentle one around your home, your garden, or your block, beginning within 30 minutes of finishing a meal. If you can only do this once a day, the evidence points to the evening meal as the highest value window. If you can do it after each meal, the benefit compounds across the full day. Harold started with the evening walk, just after dinner before he sat down for the evening. 10 minutes, most days. The second strategy doesn't involve changing what you eat, as it involves changing the order in which you eat it. It's called meal sequencing. Sometimes carbohydrates last, eating. The principle: eat the vegetables and protein on your plate first, and save the starches, bread, rice, or other carbohydrate-heavy components for last. A study published in Diabetes Care in January 2025 confirmed that a carbohydrates-last food order improved time spent in healthy glucose range and reduced glycemic variability. The size of the swings between high and low blood sugar throughout the day, compared with other meal orders, in a controlled trial setting. The mechanism. When fiber and protein enter your digestive system first, they slow the rate at which the carbohydrates that follow are absorbed into your bloodstream. The same plate of food, eaten in a different order, produces a measurably smaller and slower glucose rise. Multiple systematic reviews have confirmed this effect across both healthy adults and people with type 2 diabetes. And it requires no calorie counting, no food elimination, and no special products. Only sequence. In practice, if your dinner plate has chicken, vegetables, and rice, eat the vegetables first, then the chicken, and finish with the rice. If breakfast is eggs and toast, eggs first, toast last. It is the smallest possible change to a meal that the research shows produces a measurable result. Harold added this at the same time as the walk. Vegetables first, then his protein, then whatever starch was on the plate, last, and often less of it than before, simply because he was fuller by the time he reached it. Sucks out. The third strategy is specifically for anyone taking Metformin, one of the most commonly prescribed medications for blood sugar management, and one that connects directly to a thread running throughout this entire series. Metformin is an effective, well-established medication, and nothing here is a reason to stop taking it without your doctor's guidance. But metformin has a well-documented effect on vitamin B12 absorption. Long-term metformin use is a recognized risk factor for B12 deficiency, and B12 deficiency itself is an independent cause of peripheral neuropathy, with symptoms that can look identical to the nerve symptoms we've discussed throughout this series. This means that for some people on metformin, what feels like progressing diabetic neuropathy may actually be, in part, a B12 deficiency that has developed because of the medication being used to manage the underlying condition, layering one nerve-affecting factor on top of another. If you take metformin and have been on it for more than a year, ask your doctor specifically about checking your B12 levels. This is a simple blood test, it is inexpensive, and the Mayo Clinic specifically identifies metformin as one of the medications that can lead to low B12. Alongside the connections to thiamine and diuretics we discussed earlier in this series, Harold wasn't on metformin. His numbers had never crossed the line that would have triggered it. But if they had, this is the question he would have needed to ask. And if you are on it, it is a 5-minute conversation at your next appointment that could rule in or rule out an entire layer of what you've been feeling. Let me bring this together. Because the number on Harold's lab report and on Stableiten, and possibly on yours, is not the end of the story. It's the beginning of one you can still write differently. 3 things to take from today. 1. A fasting glucose number in the high 90s to low hundreds, the range many people are told is fine, sits inside a gradient the research associates with measurable peripheral nerve involvement in close to half of the people who have it. That number deserves more attention than a passing comment at your annual checkup. 2. The mechanism. Glycation and AGE accumulation is dose-dependent and continuous. It doesn't wait for a diagnosis, but it also responds immeasurably and relatively quickly to changes in how your body processes glucose day to day. 3. A short walk after your evening meal, eating vegetables and protein before carbohydrates, and, if you take metformin, a conversation about your B12 levels. None of these require a new diagnosis, a new prescription, or a dramatic life change. They are adjustments to things you are already doing every day. Harold added the after-dinner walk and switched the order he ate his meals. He did not become a different person. He made two small, repeatable changes to two things he was already doing: eating dinner and sitting down afterward. If you have a number on a piece of paper somewhere in your home that someone once called fine, I am not telling you to be afraid of it. I am telling you that it is not nothing. And for the first time, perhaps you know what to do about it that has nothing to do with waiting for it to become something worse. Drop a comment and tell me, do you know your last fasting glucose number? If you do, and you're comfortable sharing the range, high 80s, 90s, low hundreds, or higher, that tells me a great deal about how many people watching this are in the exact range we discussed today. I read every single one. If someone you know has been told their blood sugar is borderline or fine, just keep an eye on it. Please share this video with them. That conversation deserves to go further than it usually does. We started this series with a misfiring nerve signal at 3 a.m. Today, we ended with the chemistry happening right now in your bloodstream. That determines how resilient that nerve signal is in the first place. 9 videos. Nerves, medications, key lymphatic drainage, restless legs, the vagus nerve, asymmetric swelling, the gut, overnight repair, and blood sugar. 9 different doors into the same house, because your legs were never a separate system from the rest of you. They were always telling you about everything else. That is the lens this channel is going to keep using, not, it's just part of getting older. But what is this actually telling you, and what can you do about it? Whatever part of your body we look at next, that question is the one I'll keep asking on your behalf. Subscribe so you're here for it. And thank you, genuinely, for spending these 9 videos with me. Many of you have been here since the very first one, and it shows in the comments. I read every one of them.